All right, welcome back for those that went with us into the break. Right now we are transitioning into the Kickstarter discussion, and we will be talking about the rising respiratory infections in the land. And we have with us an official from the Lung Institute at Makerere University who will be helping us understand the basics, but most importantly, not go at anybody because of a lack of information and criticize them. Now, before I do a preamble, researchers are calling for a better care for elderly and the wearing of masks, as well as vaccinations, among other solutions, in order to stave off what appears to be a consistent and sustained wave of flus and colds, especially in children. The rampant cough and flu are being reported among adults too. According to Dr. Daniel Tumwine, a pediatrician and team leader at the Children's Clinic in Nalia, the children's cough and flu are usually caused by viruses, but the said viruses have been tested and many have turned out negative for what people fear, COVID. I was also told that some of the flus we consider, well, a flu may not necessarily be the flu that you should be afraid of. Some of it is a mere irritation, but that is medical stuff. For perspective and clarity on these matters, I have with me Dr. Bruce Chirenga. He's director, Makerere Lung Institute. Many thanks for joining us this morning.
Thank you. Good morning.
First and foremost, put us to the place we are supposed to be in terms of information on what is a wave of flu and colds in the country.
Okay, thank you, sir. Like people have noted, there has been an apparent increase in the number of people who are coughing and who are having flus. And what I have to say is that this is not usual. This is not unusual for this period alone. Usually we have about 2 peaks of coughs and colds in the country. The first one occurs around April, May, and another one around September, October into November. So particularly this wave seems to have come a bit earlier, but we would expect it that was going to happen when we have the increase in these coughs. Yeah.
Okay. So we must not be afraid. That's what you're trying to say.
Yes, we should not be afraid. They usually happen, and if people have been observant, there is always a season when these waves come. Maybe what I can say is, in the temperate climates, the flu seasons are known. Yeah, up until COVID woke us up, we didn't know that actually we have also the same waves, even in the tropical climates like where we are. But as I've told you and as I presented last week, we have 2 clear peaks where these things go up. They may not be as high as what happens in the cold climates, but the peaks are there. And these peaks, actually what we went out to study in these two projects we did, 2 large projects actually, is to find out, are these peaks also associated with respiratory infections or viruses like it is in the cold climates. Okay. Yes.
And you found that it actually isn't?
We actually found it is. We found that many of these infections that are seen in the cold climates are also here. For example, in the Kampala study, we looked at the 3 viral infections. Flu, what we call influenza. Then we looked at SARS-CoV-2, which people commonly call COVID. And then we looked at another virus, which actually many people think is not here. It's called RSV. Very common in children. And here, this was in adults who are going to health facilities to look for care. As the data has shown, you find that saturating COVID-19 was 7.8, flu 6.5, and RSV 3.3. So these pathogens, they are there, driving the coughs, but also to note that, as you can see, if this was up to, let's say 10%, the other 90, there is actually no viral infection. Maybe another 20% could be due to a bacteria which we call a strep. Yeah, but still many people do not have an actual infection.
Okay.
Yes.
Okay, when you say many people don't have an actual infection, it drives me to what is described here as allergic and environmentally driven airway irritations that are major drivers of these kind of feelings. Could you explain that? What are these irritations and what are the airways?
Yes. So maybe I will first pick out the allergy. We know that we have allergic lung disease or respiratory disease, and this is where people inherently they react to something, and when they react to something, I don't know whether I will be able to explain this. When you are exposed to something that is irritating over a period of time, your body gets sensitized, such that next time, if you are exposed to the same irritant, however small it is, your reaction is amplified. That's what we call allergy.
Okay.
Yes?
Yeah.
So there are people who have those allergic respiratory illnesses, and probably now another 30%. But what we have seen is that actually most people don't have an allergy. They don't have an established overreaction. They have an acute irritation of the airway. And this is from environmental exposures. For example, the issues of air pollution in our environment, which is high. When it goes up, you can actually get irritated immediately because the concentration is so high and you develop cough.
That is right.
And when you develop this cough, you've had these coughs, they call them rockets. You can actually just imagine that there is an actual damage on your airway. You feel it when you cough.
That is right.
Yeah.
When actually there isn't.
There is, because of the irritation, there is damage to your airway. Yeah. So those are the irritations. But also, the other irritant which we are seeing are the biological species. Yeah. There are small organisms within the environment, even here in the carpet. Okay, maybe here you guys clean so well, maybe it's not there. But everywhere, those organisms are there.
Okay.
You can't see them. But if they are suspended in the air and you inhale them, they will cause you irritation.
Okay. So when somebody says, oh my God, I have a cold today, I'm causing sick, they're not actually sick. They shouldn't be very worried. It's something that will go within how many hours or how many days?
Actually, they are sick. Yeah. What maybe let's yes.
They might not be very sick.
No. They are very sick. Depends on how they feel. It is their body.
Sure.
You have asked a good question. When these coughs come, actually people want to force them to go away in 3 days, 4 days. And actually most time when people come to the hospital, say this cough has not gone, it's now 1 week. From our studies, actually we found that the average time of resolution of some of these coughs, let's call them the rockets, the way people call them in town, is 4 to 6 weeks. You can't imagine. They take time.
4 to 6 weeks.
And what happens when during that time maybe people need to be sensitized is to use natural remedies for the cough, and then cough etiquette, how do you live, and then relax. Otherwise people keep taking antibiotics all those 4 weeks, thinking that they will force the cough to what? To go away.
Interesting there. I'm sorry, my reaction there halted your submission, but of course what I want to ask is in line with exactly that. Must we use antibiotics or any kind of medicines to treat colds and flus, or we must leave flus to outlive their cycle and do the basics, including the concoctions like ginger, a bit of garlic, lemon and orange? That is sufficient. You don't have to look for any
for most people
medicine. For
most people it will be sufficient, but what we are actually also raising is that there are people who are vulnerable, who are likely to get their cough converting into a serious respiratory illness. And these are the people that are triggering us to start this program. Older people, yeah, older where in the West is defined as above 65. I really think in Africa probably we should be around 50. Yeah.
Older.
We should bring 50. It a bit down. Yeah. But normally the normal definition is 65 and above. Children, yeah, you need, when children cough and they have a fever, you need to take it seriously. People with chronic diseases. These chronic diseases, they make you weak in some way. People with chronic heart disease, chronic lung disease like asthma and COPD, people with diabetes, yeah, people with cancer. These people, if you have any chronic disease and you get a respiratory illness, it's good to take it seriously. Everyone should take seriously, because you may think it's just an irritation when actually it's something else. But like we are saying, for maybe up to 60% of the people, they shouldn't panic, they should not take antibiotics, they should just take the natural remedies of the illness and then watch and see if they will improve.
Okay. All right, you speak about the fact that the monitoring must be done both by the parent, if in the case of the child. What is the, I don't know whether I should describe it as a time frame, but I think time frame is the inappropriate word. The transition from a common flu or a cold caused by an irritant into a full-blown respiratory infection or pneumonia. That must be something that it's a trajectory that we must understand. And what are the drivers, for example, so that somebody can know how to halt the,
the simple treatment.
Yeah, the simple treatment somebody can use.
I think that's a very good question. There are what we call danger signs in acute respiratory illness.
Okay.
One of them is that you have a very high fever, that you have chest pain, that you are short of breath, you are wheezing, yeah, you are coughing blood, yeah. So if you have any of those signs in addition to your acute respiratory illness, you probably need to be off to the clinic for a checkup. Right. Now, the fever, I have to put a caveat on the fever. Most of these illnesses will come with a fever, but this fever should be out of you within a day or two. If this fever is persisting into the 72 hours, probably this is a more serious infection of your lungs. Yeah.
Now, in that case, it means somebody is grappling with two aspects. The fever itself will need to be treated, and then pay attention still to the fact that you have an infection that you do not want to grow into viral or something more serious than that. What is the regime like when it comes to administration of medicines at that point? You're treating the fever or you're treating the cough, the flu?
You treat both. If you have a fever, you take some medicine for the fever to reduce the fever. In most cases, this is paracetamol, or what we call Panadol. For the cough, they are cough, what can I call them? Cough relievers, which are available on the market. So many of them. When you go to the pharmacy, they will look at you and they choose for you one from the counter. Some of those you don't even need a prescription. You can just go to the pharmacy and pick it, give me this, then you go and take it. Because like I told you, sometimes because of irritation, your throat is paining, you can't swallow, you are feeling so bad. Those medicines soothe it, yes? And we expect that within a day or two, the fever will go down. The other thing which persists, which people must understand, is what we call malaise. Malaise, the usual word we use is you are just finished, you are tired, you feel sleepy. You
Fatigue,
need, yes, and that comes to your question, and that's why maybe people want a day off. Yes, they need a day off for 2 or so they can be able to go through that and get back to normal.
Okay. All right. Now, there are aspects, and earlier we talked about the fact that environmentally driven airway irritation. There are people who live in communities that are either prone to dust clouds and other aspects of pollution. There was a time communities, including those in Kulambiro, and then there was Buate. It even became some sort of description to see if you had, there's a lady who had overdone her makeup and it was so brown. Somebody joked that they live in Buate because of the dust condition. Now, for people who are living in such communities, what should be their mechanisms to be able to survive these irritants? Because the dust is a constant irritant on a daily basis.
Yep.
Now, many of them might not develop flu or cough and assume they are good enough. Has that come down to immunity or the fact that they're used to the process, so the flu is no longer after them, so to speak?
Yeah, I don't think you can get used to an irritant. But it all goes back to segmenting our populations. We need to define vulnerable people. For most young people who have no chronic disease, they will be fine with the dust. It will be a nuisance. But for the vulnerable people that I've told you, especially older people, people with chronic diseases, very young children, they will actually come down with these problems. So what we are saying, there are issues, two things. There's environmental control, where we all urge that maybe the roads should be paved, the dust should be removed. But we also what we call personal protection. For example, if you know you are vulnerable, you could actually put on a mask.
A mask, yeah.
People in the taxi will want to laugh at you, but it's your life. Yeah. Do
people still laughing at somebody for putting on a mask?
Yeah, some people still say, but we are 14 people. Why is it you who is putting on a mask? So basically what we tell people in our clinics, that this is your life.
That's right.
You take your decision. Whether people think it's not good, but for you, you are protected.
And I think it's down to community sensitization. I think this one we should hammer it down a little bit more emphatically. When somebody puts on a mask, they are attending to their condition, not yours.
Yes.
The ability that you have is not what is inherent to me.
Yes.
You could be one that is comfortable and strong enough. I am not.
Yes.
So I put on a mask because of my conditions, not necessarily yours. So the stigmatization must stop. It is something that we should not actually expect that it still happens out there. People are taking precautions. If you're not taking precautions, do not try to stigmatize those that mind and take care of their health.
And maybe one other simple thing which we need to pull out is the times you move. We have the data which shows when are these roads going to be at peak hours, when is the dust highest. If you know you are vulnerable, you may actually choose to come to town off peak hours.
That's when you employ yourself.
Okay, yeah, if you employ yourself, but that is also an option.
It's also an option.
Yes.
Because you must be at
if
office.
I come at peak hours, I will reach here coughing, I will take 2 days off. So what I'm saying, can I come at 10 and leave at 3? Because we know that window, the air is relatively what? Clean. The roads are open, you can easily move. So what I'm trying to say is that if people knew what their problem is, they can come up with simpler and simpler ways to make their life better.
Okay. Now, when it comes to preventive measures, I know some people will suffer adverse effects greater than others. Are there vaccines for flu? For example, if I've seen people who take a whole year and you haven't had them wheezing, you haven't had them sneezing, And you're wondering, what is this guy made of? And then there is another one who literally every 3 weeks they have a cold and they have a flu. What must that one do in order to become like the guy who goes for a whole year without suffering a cold?
Yeah, okay, thank you. I think that's a very good question also about vaccines. Vaccines is one of the major ways we can prevent infection. There's no question about that. Forget about all the anti-vaccine movements. Yeah, vaccine is one of them. So for these respiratory infections, the good thing, many of them have vaccines available. And actually that was the focus of my presentation to the physicians.
That was at
that conference to my fellow physicians.
The 9th annual scientific conference of the East Central Southern Africa College of Physicians.
Yes.
Okay.
So elsewhere in the developed world, people who are vulnerable receive 3 to 4, 5 of these vaccines.
In their lifetime?
No, periodically.
Periodically.
Some after 2, 3 years, after then others annually. You know, the flu shot is given every year. The pneumonia shot is given every 2 to 3 years. But what we are seeing here, while there is a lot of effort to vaccinate the children, which is good, the people who, other groups of people who need to be vaccinated, like older people, people with the chronic diseases, they are not being vaccinated. So, and we are calling for all of us as doctors to start looking into this in our small clinics, hospitals, but also at policy level in the Ministry of Health, so that these vaccines can be accessed. I will name some of them. For example, I told you 6.5% people have influenza. We have a vaccine for influenza. We have a vaccine for the pneumonia, what we call strep. We have a vaccine for COVID-19. It is still there. Then we have a vaccine for RSV. The RSV vaccine came out 2 years ago. It's not yet in most of the low-income countries. But the other 3 vaccines we have, and we recommend that people have, and at the Lung Institute actually, we give the vaccines. And I will tell people one example. When I recommend vaccines for our older people, like you bring your parents, everyone will say, no, why are you vaccinating? This is not a child. But if they accept and they take the vaccine, they will bring more people the following season.
That's right.
Because they will come and tell you, you know what, doctor? Mosei this time did not catch the cough when the children came back for the holiday. This thing of yours could have worked. So we need to encourage people to offer these interventions to people who are eligible. Not everyone.
Not everyone.
Not everyone. Like if
like
you are,
said, older.
Yeah, older.
55,
with if you have a
plus.
problem, you need to take this vaccine. Because the important thing is, when you come to the hospital bed, the people admitted with severe respiratory illnesses, they are from those groups. Most of you will carry the pathogen around, you will recover from it, but it will go to a vulnerable person who will end up on a hospital bed. And sometimes the outcomes are not good.
Not good at all. Okay, so we have these vaccines readily available in the low-end medical centers or drug shops.
No,
and how
that
much
is now our movement.
Okay, and
the
how
vaccines
much
are expensive. Currently, they are not given by the public health system. Yeah. Actually, you may actually find the same vaccine is available to be given to children, but it's not available for the adults.
Persons, yeah.
Yes, for the adults, older person who need them. So you will find that the vaccines are not there. And actually the problem is, most of us, even the health workers, still don't believe that this thing is a problem. Yes, okay, in America they vaccinate, but for us here, we don't have these things. And the purpose of our studies was to show that actually these pathogens, these infections are saturating in our what? Environment. And you know, for scientists, to convince them, you have to show them the data. And that's the data was showing them.
That's right.
Yes. There is actually another study which we did countrywide. And then we found that in that study we measured the outcome, mortality. We found that while the mortality was 0.5 in young people who had the infection, it rose up to 2.5 in people who are what? Who are older. That is almost 5 times. So we need to generate this data and show it to the people.
Okay.
But
the
also,
data you generated, was it a population-based study or
no, hospital-based?
Who comes?
Yes, who comes. Of course, that's the other weakness.
That's the weakness, because if you're basing the study on who approaches the healthcare system, then it might be loop-sided at a certain point. You need to be able to intervene and engage so that you have a concrete conclusion.
Yeah, from the population level.
When is that going to be done? What kind of movement are you driving on that?
Yeah, we keep planning. We keep planning. For example, the Kampala study was funded by government through the Ministry of Science. Maybe moving forward, as we pull out this data, maybe even the people in policy will see the need that actually you need now to go to the population and find out how many people are carrying these pathogens. But for now, the little that we have, we want to use it to advocate that at least, in my view, I think if you are 50 years and above and you have a chronic condition, HIV, diabetes, hypertension, asthma, COPD, you should be prioritized. Okay, all the other old people need the vaccine, but those ones probably we can be waiting.
Are more vulnerable.
Yes, these ones are really more vulnerable. Because remember, even during COVID, the people who are coming down were people with these problems.
That's right.
These viruses, they behave in the same way. So we need to prioritize those people. And how can we do that very fast? We need to really engage. If the Ministry of Health could make these vaccines available free of charge for these groups of people.
You've just preempted my question, because I was going to refer you to the fact that you say the public healthcare system has not rolled out these vaccines. And I was wondering, is the issue not one of the apparent threats? Government is known to offer vaccines most of the time.
And we have a lot of vaccines.
Yeah. So if we have a lot of vaccines and they are not available to the population, just give me an idea, who should I be calling next on the show to ask that question? Is it the National
Immunization Program? But like I said, I think even from the academic point of view, we need to bring out these things. Because, you know, the public health systems, they pick information from the academia, the things which we are bringing out, is this really a priority?
That's right.
Now, you ask a very good question, is that we have so many vaccines for children. Adding these few older people would not really be a big issue. It's just a matter of changing how we are looking at it. But also, for people to make a policy, this one I have to mention very clearly, you need to put the data on the table. Like I'm telling you, if you went downtown and asked people, Ugandan health workers, do we have RSV here in adults? They will say, no, it's not there.
It's not there. RSV is what is
one
it?
of the viruses.
Respiratory syncytial virus.
Yes, just an example. So even the flu.
I had no idea too.
Yeah, people will say, no, it is not there. Those are things from the Muzungu land.
Okay.
So you need to first now, we need to start slowly by putting this evidence on the what? On the table. But also the other thing which we need to put on the table is, can we show that if we vaccinated these people, it would make a difference? Yeah? In the number of people who come down with bad outcomes. And then if now we can start to advocate. So I don't want to appear like I want this to be a magic bullet. I am aware how policy is made.
That's right.
You cannot wake up one day and say, take all these vaccines.
The action.
Yeah, remember government or the Ministry of Health, so many health priorities.
That's right.
For you to put in another one, you have to bring the evidence and the data. And the data is just emerging.
All right, so we need a bit of time for us to have sufficient data.
Sufficient
and also
data.
Create a good movement behind to push that narrative.
Yes. Interesting
there. I would suppose that as national policy, matters of public health be given the ultimate attention that they deserve, because after all, a healthy population is what we all want. Okay, let me ask you a question that might put you on the spot, and many of those you work with. When we listen and monitor what's happening on international televisions, we see what appears to be a deliberate and consistent effort by governments elsewhere or medical personnel to publish information and also offer information on emerging trends and waves of diseases and patterns that they think if the public is armed with this information, they would make better decisions. What we do have here, and it's evident, I'm not trying to throw an allegation that is out of this world. Why is it that the Ministry of Health and medical personnel in Uganda wait for the public to cry out before updates are given unto us? Isn't it healthy to update us prior to an outbreak or a particular pattern beginning to appear the way they do? What is the problem?
I think I agree with you. Our engagement with the media is far lower than it is in the developed world. But it is improving.
Okay.
Yeah, it's improving. One, the Minister of Health has a public relations department.
That's right.
I think it is headed by a journalist.
A former journalist.
Former journalist. I thought journalist is a profession. Once a journalist,
no, there is a
forever.
There is a tendency for practitioners to have a complete mindset change when they go into public relations, because it's a different track of way of doing things.
Okay,
Yeah.
okay. I didn't know that. But at least he has some training. And then at the Lung Institute, I think it's now 2 years, we have a public relations person who is also from journalism. And she's really trying to really make sure that we put
The information is out there.
out. Now, what is our fear? I think let me now tell you what our fear is. Our fear is really being misquoted on sensitive issues. Yeah? So if we can have more media health trainings such that the journalists also know where we are coming from.
That's right.
Yes? And then we come together. Personally, my fear is usually when you say something, people may not get it, and then it causes some discomfort.
Confusion.
Yes.
You get criticized.
And you know we have supervisors and supervisors. So that's why you see in most of our health institutions, we want the new public relations people who are the journalists in them to take lead.
Okay.
Yes, with management to see what is it that can come out to avoid misinformation, because health and medical care is a very sensitive matter. But that is not a reason for us not to give you information. We have seen now the Minister of Health is on most of these social media platforms. Yeah, and they try to put out information. What I'm trying to say that it is improving, it can be better. And you bring in an issue that we should not be the one putting for information. We should be packaging information and giving it to you to take to the people.
In fact, relaying that information should be a critical KPI, that is a key performance indicator for any officer at an institution. So much so that, for example, it could be, and I don't know whether you guys at the Lung Institute should pay for this. This is advice. It could be either 3 monthly, so that you come out and update us, even if the change of information given to us is slight, as long as it helps us explain a certain thing that is happening.
Yes.
Let me tell you one thing. The average African, when they are dealing with what they don't know, tend to go spiritual.
Yeah.
Okay?
Yes.
Now, there is the problem, because they tend to believe that the spiritual world is responsible for much of what is going on, because they don't have an explanation. And when you bring science to it, you realize that the spiritual aspect was basically some sort of a hoax. So as a population, that is a dilemma. So the easier and the earlier information is relayed, the better. That is a simple plea. All right, let me delve into the 9th Annual Scientific Conference of the East Central Southern Africa College of Physicians. I know this was an integral part of the paper, but it wasn't what only thing at the conference. What else must we pay attention to that emerged at the conference? Were there critical resolutions that the nation ought to know?
Unfortunately, I may not be able to speak to that.
Okay.
The association has its leadership and people who organized the conference.
Yeah.
I can link you up with the team. I don't want to misrepresent them. But what I can say is that it was a very big meeting. All physicians from East and Central Africa, big conference.
Physicians being doctors.
Doctors, a group of doctors, who treat most of what we know as medical diseases, of adults. They were at this meeting, and I got an opportunity to present to them this paper. I may not be able to speak on the outcome.
On the outcome of... all right, as we enter the final bend of the discussion, people are beginning to become a little laid back on COVID, but I'm told COVID cases are still within the population, though the numbers apparently between 5.3 to 7.5% thereabout. Is that something we can treat as insignificant and go on with life?
I think there's no question that the burden of COVID-19 has gone down tremendously. We all know because we are here. The remaining saturating or transmissions are of a concern to us from the scientific point of view. One, whenever you give a virus or a pathogen a chance to be transmitted from one part to another, you are actually giving it a chance to change. Remember what we used to call mutations. So we remain on high alert that because of this low-level transmission, actually a new variant could emerge, which will evade the immunity we have from prior infection and the vaccination we've had, and therefore it could take us by surprise. Now, what we are doing now, the Ministry of Health and research institutions like the Lung Institute and others, we are doing surveillance. Okay. Yes, we are monitoring the trends, such that it doesn't get off hand. Should we see trends of the change, we'll be able to warn the public immediately. But as it is now, people should go on with their lives. And like I said, if you have a cold or a respiratory infection, please put on a mask when you go to public, or stay at home. And if you know that you have a weak system, and those are the people I have mentioned, if you have a weak system, please make sure that you are updated on your vaccines for COVID-19, and that should be fine. Okay.
All right, that's very good information. The reason I asked about COVID is because our head of state continues to be very, very consistent on the use of the mask, and most of the people who access him must undergo the COVID test, and that is of course very important, and it says something. Many thanks, Dr. Bruce Chirenga, Director, Makerere Lung Institute, for what's no doubt very good and timely information and perspective that has emboldened our understanding of matters. So now you know, don't be in a crisis. These things can be dealt with before you can get to points where crisis is unmanageable. That will do it for our Tech Note discussion. Stay with us. We'll be going into a break. My man Stephen Mbide promised earlier in the program that he'll be going to Lugogo, where there is a mushrooming Chinatown, and apparently there's a little bit of furor on exactly why the goods there are half price compared to what is in downtown. That is a new war that is emerging, and we shall be keeping tabs on that story. Stay with us. We'll be right back.